very much. ISOT midterm ISOT. Today I am presenting the outcome of the kidney transplant coming from the donation after circulatory death at AIIMS Nagpur. I am Dr. Amol Bhawane, Assistant Professor in Nephrology, Department of Nephrology, AIIMS Nagpur. So straight away I will come to the reality. So this is the reality today's need versus availability. So our annual rate of transplantation is only 15,000 against the need is 5 lakhs. So for that we have our current rate of donation is less than 1 per million population. What we need is 62 per million population. So long way to go. So this is the reality, and that's why this is the happening. Because for every 2 lakhs kidney we need, we are just transplanting 10,000 kidney. And the scenario is more scary about other organs like heart, which is totally depend on deceased organ donation. So this is the reality check. So in India, if we see, we will think that India is the third most, as far as volume of transplant is concerned, the third most transplantation happening in India. But in reality, that transplantation is coming from 80 to 85% living donation. Deceased donation is only minuscules against the Western countries like US and UK, where the things are reversed. That is 80 to 85% of transplantation coming is from deceased donation. So this is the fact. So coming to the deceased donation, the things is worse also. If we forget the COVID period, if you compare the data from 2016 against 2022, not much improvement. That improvement is very slow, and surely that will not meet our goal. So we need to expand the donor pool. So how to expand the donor pool? So in case of living donation, we can expand by ABO incompatible transplantation, kidney pair donation, desensitization protocol, but that is actually saturated. We are already stretched them too much. So we can utilize the donor from positive donors also started utilizing in living as well as in cadaveric transplantations. So the actual need is to increase the deceased organ donations. So in that also, we can try to use a expanded criteria donation, dual kidney donation from the pediatric or marginal donor. And the one thing is that donation after circulatory death, which is happening in very minuscule number, very minimum number in India, we need to expand our donor pools. So what is the global scenario of DCD? You can see in the graph, there is nowhere India is written. That this is the reality of DCD in India. In fact, in major Western country, 20 to 25% of their transplantation out of their deceased donation is coming from the DCD. So why? Why more DCD in the Western world? Because they have clear-cut guidelines. It is covered under the law, and as a society is better acceptance. And most importantly, they have more robust deceased donation program. Without more robust deceased donation program, DCDs won't be happening. So what is Indian scenario? You can see actually the deceased donation is also minuscule, and in that DCD is very minuscule. You can see 1 or 2 donation that is in a 1 or 2 institution only. So this is the reality and this is the fact. So whatever Indian data is from these 2 great institutions, that's these 2 premier institutions, what we are learned from these institutions, that IKDRC Ahmedabad and PGIMS Chandigarh. So we are thankful to these institutions. So first, DCDs happen in the IKDRC Ahmedabad in January 1999. So from January 1999 to 2012, IKDRC performed 33 DCDs, which are mostly a controlled DCD. Hence, the warm issue time is less than 20 minutes. Patient survival and graft survival is comparable to that period of DBD patients. So DGF is 36.4%, and they conclude that they have better graft survival when donor age is less than 70, which is expected. In PGIMS Chandigarh data, they have done DCD from 2011 to 2015. After that also they have done DCDs. So they have mostly uncontrolled DCD, hence the warm ischemia time is 68 per minute, and they have against a good outcome, which we can compare to the same period donation after brain death. So they found that for them there is better outcome if they continue doing CPR till the OT. So this is from these 2 institutes. We are the latest entrant to this quest for the expanding the donor pools. AIIMS Nagpur, we have a very short journey. We are less than 1 year old also. 1 year old, like our first transplantation happened less than, even before our first, we got the permission of organ transplantation, we are into the donation for the deceased donation. So we identified 2 VSD and transferred to the another center having the permission. In the very same month, we got the permission for organ transplantation. We done our first live related transplant in May 2023. In the next 2 days, we done our first DBD. In next 6 months, we done our first DCD, and in this month, we have done our second DCD. So this is our short and small journey regarding DCD. So Nagpur as regions is also growing, is having more and more disease donations. In last year, we had 35 donations, out of that 7 are from the AIIMS Nagpur. In this year, we already had 17 donations, out of that 8 are from the AIIMS Nagpur. As an institution, AIIMS has 22 kidney transplantation. We have a small experience of kidney transplantations. Out of that, 75% are from the deceased donation. Majority are from the DBT and 4 from the DCD, only 5 from the live donations. So this is the donor profile coming to our institutions. Our first DCD is 47, that happened on the 3rd of December 2023. 47-year-old female with head injury, ICU stay of 8 days. So serum creatinine at presentation is 1, at the time of retrieval is 1.73. Our second patient had a 26-year-old male, had a cardiac arrest at home only. So he resuscitated and he got hypoxic brain injury. So he came in a vegetative state, and their family is very motivated to donate the organ. So they have ICU stay of 20 days. Serum creatinine as presentation 0.93 and retrieval at the time of retrieval 1.5. So there are the sequence of events in both the cases are different. So I will take you into the sequence of events. In first case, we had a patient, we could perform the first apnea test, but we tried second apnea type, we failed because patient is getting saturated, desaturated, there is a hypotension, we are not able to perform second apnea test. So suddenly cardiac arrest, a patient went into, at the midnight went into the cardiac arrest, CPR started, patient transferred to the OT. We resuscitated the patient successfully and stabilized on the OT. So we asked the patient, we explained everything to the family, and family are more than ready to give a consent. So they are not willing for further resuscitation, hence they give a DNR consent. We also done a counseling for DCD, they were agreed to it. We have taken a consent for femoral cannulation. Unfortunately, she had again a second cardiac arrest. After that, we waited for 5 minutes of no touch times and we declared a death. We taken return consent for DCD. We started the perfusion immediately with the femoral cannulation only. We took, super rapidly, we opened the patients. We took the supraciliac aortic control. We ligate the opposite side common femoral vein, common femoral artery. Blood is went out through IVC, and we done a super rapid retrieval. So this is the first case. In second case, the problem is that we are not able to do even the first apnea test, because although the patient has hypoxic brain injury and he has multiple arrest, he is in a vegetative state, but his all reflexes of brainstem reflexes are present. So we have not attempted apnea test in this case. In this case also, unfortunately, patient went into the cardiac arrest. We have given CPR for more than 30 minutes. In this case, we are not able to revive the patient. Patient went to the asystole. We observe 5 minute no touch period, dead declare. Family consented for DCD, and then we shifted the patient to OT. We taken rapid incision, we taken supraciliac aortic control. In this case, we have done perfusion through aortic cannulations, and IVCs went out. So there are some differences between first and second cases. In first cases, we are able to do at least first apnea test. In second case, we didn't got that chance also. So regarding the outcome of the first DCG, which was happened on 3rd December 2023. So in both the cases, we have used standard inductions and tender immunosuppression. Warm ischemia period, as I discussed, is 15 minutes in both the cases. Cold ischemia time is 2 hours 45 minutes in first case, 4 hours 45 minutes in second cases. We have nil output on the table. We have no output on the first day. So there was a DGF in both the cases. Patient require RRT supports. Days to normalize, it took 16 days to normalize creatinine in case of first recipient, 20 days to normalize creatinine in case of second recipient. Urine output at the discharge is 5 liter in first, 4.5 liter in second case. Lowest creatinine we could achieve is 0.97 in first patient, 1.06 in second patient. Serum creatinine at discharge is normal. Today also, at the 3 months, serum creatinine is 1.18 in first case and 1.13 in second case. There was no episode of rejections. Both the patients are doing fine. So coming to the outcome of our second DCD in this month, which we have done 7th April, both the patient, again, we have used a standard induction and immunosuppression. Warm ischemia is 79 minutes in both the patients. Cold ischemia is 3 hours in 11 minutes in first and 5 hours in 11 minutes in second patients. The good thing is that in case of second DCD, we have a urine output on table. There's 250 ml urine output in first case and 100 ml urine output in second case. So we thought everything will be great. But then there is some unfortunate event. In case of our first kidney, we have to lose the first kidney graft because of massive DVT in the iliofemoral region, and that DVT is in the graft vein also. We have to do graft nephrectomy. Second patient's today's creatinine is 2.8. Her urine output is 4 to 4 liter. Now she is off dialysis and she is recovering. So this is our experience about the second outcome of second DCD. So what insight we gained from this experience? Our small experience, DCD transplantation can be performed with a tertiary care infrastructure with an active deceased donor transplant program. This is a must. Short-term outcome, it is very early to say outcome, but short-term experience of DCD kidney transplantation appears satisfactory. Proximity of operation theatre and ICU offer advantage to us because it will surely cut down the war mixture time. In our institution, whenever brain death happen, we have one dedicated bed which is just near to the OT opening in the surgical ICU, and it is 24/7 reserved for that patient only. And one have dedicated nursing officer, dedicated all intensivists for that only. So that is advantage for us. Presence of dedicated team and super rapid coordinations plays pivotal roles. Femoral cannulation of perfusion help to cut down with war mixture time in case of first DCD. Very short war mixture time for in-house recipient contribute to the good outcome because there is no taker for these kidneys. In the both time during allocations, no one ready to take this kidney. So hence we have taken this kidney, and good thing is that we had backup also for that. Failed DBD second apnea cases are potential for DCD donors. We should try, we should not let them go waste. Antemortem discussion and shifting to the facility which is capable of doing such things like DCD is valuable. Early cross-match and tissue typing help to identify and mobilize the suitable recipient. What challenges we could face? There is a lack of awareness among the stakeholder. Like in first case, we had an MLC patient. So it is very difficult to explain to the patient to do the panchanama and to get a NOC from that police officer. We have to go to the higher authority till the commissioner. We have to explain. Then at the middle of the night, we have to show them the literature, why you are doing these things, not happening in the Maharashtra till then why you are doing. So these are many questions about that, but then our administrators able to solve that questions. So we are lucky to that we have good administrators and good administrative willpower. So there are lack of awareness among other stakeholders also, like there is no recipient in the group for the DCD kidney. Both the kidney will have to take both the kidney. Liver team has come from long distance, but then somehow they thought they are not sure about the timing of the cardiac arrest. So they have not taken the organs. So there are lack of acceptance among the stakeholders also. No proper guideline or law regarding withdrawal of life support or DCD. It is not yet included in the THOTA. No clear guideline on how to do perfusion, preservation, retrievals. And one thing is that it is a resource intensive activity with lot of uncertainty. We have done 2 DCD, but we failed many times. But we keep trying. Controversial, it is somehow lack of consciousness, and there are some things which is gray area, whether we should go for femoral cannulation, whether we should do CPR after declaring death till the OT. So there are some gray area. I will not use word controversial, but whenever we use the word controversial, we try to stay away from it. So better word is a lack of consensus. So we should have a consensus now. There is uncertainty outcome, and hence the less acceptance among the stakeholders. But the outcomes are actually good. Both the institution, PGI and IKDRC data and outside data shows the good outcomes. So what are the way forward? For a society, it is very easy to accept cardiopulmonary death rather than the DBD. When we counsel the patient DBD, they say then usually say that अभी तो हार्ट चल रहा है, सब कुछ तो मॉनिटर में दिख रहा है, हम कैसे ऑर्गन दे दें? But DCD में तो वो भी समस्या नहीं है. There are, as a society, it is easy to accept the cardiac death rather than brain death. If we systematically implemented it, it is a potential to have bridged the gap between the need and availability, and is a small step toward the self-sufficiency. We should try category 4, at least to the beginning, then we can try category 5 also. There are the advanced medical directive from the Supreme Court in March 2008. Now it is very much simplified. In January 2020, they have given a detailed procedure how to do withdrawal of life, and in a way to the type 3 DCD. Ideally, withdrawal of life support should be an isolated thing, organ donations, but there are very good Supreme Court directives. It is yet to include it in the law. Outcomes are, I already show you, it is comparable and acceptable outcomes. Key to success is administrative willpower, super rapid coordinations, and of course the teamwork. And as the theme of this conference, concluding conference, that we should move from controversies to the consensus. And it is time to move from controversies to the consensus, and we should try to expand what actually is expandable. We should not stretch which is already overstretched. So thank you. This is our team from AIIMS Nagpur. Thank you very much.